I'm Dr. Anusheel Munshi. I'm the head Department of Radiation Oncology at Manipal Hospital, Dwarka, New Delhi. Over the next 15 to 20 minutes, I would be talking about evidence and indications of SBRT spine in patients with polymetastatic disease. We all know the incidence of SBRT or SABR is on the rise. Right from the year 1984 to 2020, if we see the list of publications for both SABR as well as SBRT, we can see a steep increase in the last few years. And this increase actually has been for various reasons, including the availability of technology. And we have kind of published our perception and our impression about this rise in the incidence of SBRT. And this increase in SBRT and SABR has also been kind of triggered by the pandemic that we are going through. And that has also kind of increased the interest in shortened version of radiotherapy treatments. So in oligometastatic disease, as the preceding speaker would have alluded to, we could possibly compare SBRT as well as surgeries side by side in the oligometastatic state. And these are the differences in terms of precision, tolerability, need for GA, post-op recovery, tissue diagnosis, cost, so on and so forth, and survival benefit. But this comparison probably is irrelevant for polymetastatic disease because obviously surgery does not represent a very viable option in that scenario. Now, we are all aware of this very landmark publication that appeared in Lancet Oncology in 2019 from Palma Group, in which this was the SABR COMET study, a very famous study. They took almost 100 patients, 1 to 5 metastatic lesions with life expectancy more than 6 months, and randomized them to palliative standard of care treatments alone, the control group, or standard of care plus SABR. And they found a reasonable improvement in overall survival using SABR across the body sites and across the number of metastatic lesions and across the location of metastasis with an impressive hazard ratio. So that triggered the interest that, okay, if we are achieving some success for oligometastatic disease, can we extrapolate this success to the polymetastatic scenario as well? But the question is, how do you define in the first place polymetastatic state? And there are varying definitions that have been used by various authors, including more than 5 systemic metastases, 1 spinal metastasis, and less than equal to 5 systemic metastases, or 5 spinal metastases and no other systemic metastasis, or more than 10 metastases. Various authors, different definitions, and that has added to the complexity of the situation. Remember, the SABR COMET 10 study that is going on has considered up to 10 lesions as oligometastatic lesions. So polymetastatic lesions, why should we consider also? Why should we treat these lesions? And the possible postulates or the possible reasons could be persistent tumor in the local site or distant site is a source of progression, can lead to further metastasis. Polymetastatic patients may have improved overall survival with aggressive treatment. And the SABR promise in providing progression-free and overall survival benefit in the oligometastatic state possibly can be postulated that benefits could extend to the polymetastatic state. And then just because we have sensitive diagnostic modalities, does it mean that we should ignore these patients who were just found polymetastatic just because we have more and more sensitive modalities of imaging and treatment? Should we ignore these patients? So possible aim is that we shift this curve towards the curve of the oligometastatic patients, possibly, so that these patients have further improvement in their local control disease-free survival or survival rates. And I bring to your notice this important letter which was published in Nature And I would strongly recommend everyone to go through this very, very important publication, which talks about how metastases form and how they spread. So after a long period of development, metastases usually occur in the form of spread between distant sites, and there are separate waves of invasion directly from the metastatic sites. Waves from the primary tumor are lesser common. Waves from metastatic sites to other sites, they are probably more frequent. And that is how the metastases are formed, and that is how they spread. So that kind of also throws some light on how we should be going about treating this polymetastatic state. I was talking about the sensitivity of the newer imaging modalities. Now, if we compare, these are not scans of 3 different patients. This is the same patient which has been scanned through different diagnostic modalities. So this is the scan of the technetium MDP bone scan 99. This is the sodium fluoride PET, and this is the PSMA based PET. And you can see this is almost looking like an oligometastatic scenario on the left side, and as we move towards the right, it's becoming florid, kind of a polymetastatic state. So this is what the new diagnostic modalities can do in terms of imaging. So possible aims for SBRT in polymetastatic spine could be local ablation of polyprogressive disease, local ablation or consolidation of polyresidual disease, and the larger goals are improvement in local control, PFS, OS, quality of life, and so forth and so forth. And these terms have been very beautifully discussed in this article by Matthias Uckenberger. Spinal SBRT has been done for quite some time now. In the past 10 or 15 years has gained significant traction, and various dose and fractionation regimes have been used, ranging from 14 gray single fraction, 16 gray single fraction, to 24 gray single fraction, to 24 gray in 2 fraction, to 30 to 35 gray in 4 to 5 fraction, and so on and so forth, with very impressive local control rates ranging from 80 to 90%, and very impressive pain response rates, albeit at the cost of an important complication or side effects, which is the compression fracture, which has ranged from 10 to 20 to 30% in these series. I'm just taking one study out of these studies, which was published in around, I think, 2015, 24 gray single fraction to the vertebra, different levels. And however, most of them had solitary lesions in the spine. You can see the impressive progression-free survival rates post SBRT, but also around 20 to 30% rate of vertebral compression fractures post 24 gray SRS to the spine. Now, this study, perhaps more relevant to the topic that I'm talking about, this came, it's a multicentric study. It's a multicentric study for oligometastatic and polymetastatic spinal tumors. If we see, they had around 215 patients oligometastatic, 178 polymetastatic. If you see, they had chosen no other site of metastasis and 1 to 5 spinal metastasis as oligometastatic patients, or 1 to 5 spinal metastasis and systemic metastasis and 1 spinal metastasis as oligometastatic. For polymetastatic, they chose more than 5 systemic metastasis, 0 spinal metastasis, or 1 to 5 systemic metastasis and more than 1 spinal metastasis, or no other site of metastasis and more than 5 spinal metastasis. So if you want to see purely polymetastatic spinal tumor with no other metastasis anywhere, again, very poorly represented in the study. And this actually is the scenario across most of the studies when you talk about polymetastatic spinal tumors. This is not a very big entity of patients that comes across as you go through studies. So in this particular multicentric study, what they found is that when they compared oligometastatic and polymetastatic patients, the oligometastatic patients were actually doing well compared to polymetastatic patients. This is the graph for the oligometastatic, the percentage of patients which died after treatment. This is the polymetastatic. So polymetastatic, more are dying. Now again, this is the group of surgery plus minus RT, and this is the group of RT alone, more or less showing the same trends, a significant advantage of around 77% versus 65% at 6 months, oligometastatic versus polymetastatic disease. Again, the big question, were all the lesions addressed by surgery, RT, or both combined treatment? We really don't have the answer going through this study. And this is a very, very important question that everyone should ask. A fine print, again, as we can see, of all the patients with oligometastatic disease treated with RT alone, 73% were treated with SBRT, but in the case of polymetastatic disease, who were treated with RT alone, only 36% were treated with SBRT. So the inclination of using SBRT was probably going down as we are coming to the polymetastatic disease. As is well known, we had impressive control rates with the use of SBRT in oligometastatic disease. Quality of life, they found significant improvement in quality of life for both oligometastatic as well as polymetastatic patients. And what they found is that there was improvement compared to baseline in NRS pain scores in both groups, and polymetastatic patients had improvement in physical component of SF36 as well. This again is a very important study from the Sehgal group, in which they actually compared SBRT versus conventional external beam radiotherapy in patients with painful spinal metastasis. It was a phase 2-3 trial. And what they found is that at the median follow-up of 6.7 months, 35% of the patients in the SBRT group versus 14% of the patients in conventional RT group had complete pain response. And this was statistically significant. So they did find significance statistically towards favoring SBRT for spinal lesion. Again, the study from Sunnybrook, Toronto, 605 patients, 1,406 spinal segments, quite impressive. And they tried to see the prognostic factors associated with surviving less than 3 months versus greater than 3 months, specific to SBRT, and they also analyzed the late events. So primary site, again, as we know, a very, very important factor in terms of overall survival. Breast doing very well as compared to other sites. Similarly, oligo versus non-oligo, and non-oligo would mean poly. So oligo doing well compared to the rest of the group. Again, as we know, the rate of the side effects are important. When we talk of SBRT of the spine, rate of compression fracture at 3 years was around 10%, rate of plexopathy at 3 years was around 2.2%. I want to shift gears a bit now and bring in the evidence or a factor that we have seen in cranial stereotaxy. Now, after having talked about the number of lesions as an important factor in cranial stereotaxy, we started also talking about the lesion volume. And as this important study shows, that volume less than 10 cc versus cumulative volume more than 10 cc also was an important factor in terms of overall survival. So I'm asking the question, can this also be extrapolated to extracranial SBRT? So by that, I mean that although it's just been talked about in some very preliminary studies, so as the volume goes up, can we have a threshold for where we have the cutoff for oligometastatic disease, and as slightly higher volume than that, a cutoff for polymetastatic disease, beyond which we'd say that, okay, this is the threshold beyond which we'll not be considering patient for SBRT in terms of the volume. So probably you need to think beyond numbers and talk about volumes as well in SBRT spine. And as we know, the Palma study, which I was talking about earlier, published in 2019, had a cautionary note because there were around 5%, which means an absolute number of around 3 patients in the SBRT group that had grade 5 events of death. So while we are talking about SBRT in polymetastatic disease, I think we should be aware of about these figures and take note of these important numbers. Which are the indications that have been used in trials in polymetastatic disease? No standard of care systemic therapy option exists for the patient, these kind of patients. The patient refuses further standard systemic therapy. No intent to deliver systemic therapy for 3 months after enrollment. And it is believed generally at the discretion of the treating oncologist that he can treat all sites of disease safely in a planned manner and in ensuring safety for the patient. Which spinal polymetastatic disease patients are unlikely to benefit by SBRT? Poor general condition, poor life expectancy, less than 3 months, inability to treat all sites of disease, very large size of metastasis, more than 5 centimeters, frank cord compression, impending fracture, and caution. Please observe caution for patients who have ulcerative colitis, Crohn's disease, lung disease, lupus, and so on and so forth. The way forward probably means that we need to individualize. We need to individualize based on the experience that we have gained in the past. And of course, besides the usual clinical factors that we have already known from various body sites, we probably need to look into the molecular aspects and molecular predictive marker. miRNA had shown some promise, but again, this world is so complex, the molecular world. We recently had a publication around 1 or 2 years back, which said that it's actually not ready for prime time. It's not leading us to differentiation between an oligometastatic state or a potentially polymetastatic state of cancer. And that is what we really want to know. The other thing which we want to know is the expected overall survival benefit of spinal metastasis patient. We had the older models ranging from 1976, 1995, 2008, and we have the newer models of newer studies which talk about more advanced technique, including AI-based models and other things such as nomograms. And these can have the survival predictions can have implications service the kind of effort or the intensity of effort that the radiation oncologist should need to put in for management of these tumors based on the expected survival data. Of course, we are having some exciting information coming from the immunotherapy world as well, and immunotherapy combined with RT or combined especially with SBRT, because SBRT has been found to trigger the immune response a bit higher than conventional radiotherapy. And this combination perhaps is a win-win combination. Some preliminary data that has come out seems very exciting. The ongoing trial, I'm just picking one trial which I find is quite exciting, the ARREST trial, which is actually a modified 3+3 design phase 1 dose escalation trial. And the authors have done something very interesting and exciting. So basically, they are going to give 6 gray per week. And starting from 6 gray per week into 2, they are going to add 6 gray, 6 gray, 6 gray, and going up to the limit of 6 gray per week into 5. That means 6 gray into 5, 1 session per week. So, and obviously they would not be treating all the lesions of the body in one go. So they probably would divide the body in 2 or 3 portions and multiple isocenters, and probably treat one portion of the body, say upper third, middle third, lower third, like that, with one fraction. So it's not so, these things are not so straightforward as they seem, not so simple as they seem when we especially talk about polymetastatic disease, and one needs to be very, very careful about this. I've talked about evidence. Now I'll move to technology part a bit, just a few more slides about the technology and the exciting technology that we have that is enabling us to talk about polymetastatic disease, taking the evidence and the experience that we have from oligometastasis. The principles remain the same. Try to achieve a sharp dose fall off, a high dose hot region, a sharp dose fall off, and a good immobilization, comfortable for the patient, and ensure in the planning stage a rapid fall off from the PTV, maintaining the critical parameters such as the PTV distance from the spinal cord, ensuring that use of CBCT is done in almost all situations of SBRT spine these days. And IGRT surface guided systems are there to further kind of ensure the accuracy of treatment. And one of the more exciting things that is coming up is IGRT MRI based spinal SBRT. There's no additional imaging dose, larger variety of functional imaging is there. There's better delineation of tumor OR, more accurate patient setup, adaptation to interfraction anatomy, better soft tissue contrast than CBCT, so on and so forth. Of course, the cost factors of these new machines remain an issue, and the treatment time per session remains an issue. Various kinds of systems. We started with the offline, we have the online systems. You have 4 vendors in the market. So basically a number of machines. I would not be able to recommend any of these machines. What I would say is that essentially we need established protocols, robust planning, stringent QA, imaging solutions, good imaging solutions, and good treatment delivery techniques, whether it's IMRT, VMET, or ARC, and probably a 60th couch whenever possible. Upcoming advances: biology-based SBRT, proton-based SBRT, flash SBRT, AI-based SBRT, but the final aim would be personalized SBRT for polymetastatic disease. What are the challenges for SBRT for spinal polymetastasis? Inconsistency in fractionation schedules that is being used. So we don't know what is the optimum dose, what is the optimum fractionation. Issue of dose volume constraints of varied hypofractionated regimens. What exactly is the dose volume constraint that we use that we should be using for a particular fractionation? Optimum motion management or image guidance for each technique. Adequate reporting, long-term follow-up. To summarize, polymetastasis and spinal polymetastasis especially, they are upcoming entities. There is rationale for integrating local therapy in polymetastatic disease. We need to identify the subset of patients with polymetastasis that would do well. Immune enhancing effects of radiotherapy are very encouraging, especially SBRT, and so are the early clinical trials. There remain challenges which include preclinical challenges, clinical challenges, technological challenges, and of course, we are very, very eagerly awaiting the outcome of trials, including the hard evidence of overall survival benefit for use of SBRT in polymetastatic disease. With those words, thank you all very much for a patient hearing.